Hello and welcome to the final Rural Doctors Programme for 2008. I'm Gerry Gannon. Thanks for your company. Well, in tonight's programme, we'll be focusing on some common sight and hearing problems in both children and adults. We'll be hearing from Dr. Harvey, the Senior ENT Surgeon at Princess Margaret Hospital, and Janet Mclean, Coordinator of the Western Australian Newborn Hearing Screening Programme, about how undiagnosed hearing problems in children can affect their education for the rest of their lives. And ophthalmologist Dr. Anita Tandon and orthoptist Sarah Ashurst from Princess Margaret Hospital will give us some tips on child sight screening. Those stories later, but right now let me introduce our panel for this evening. Dr. David Jameson is with us once again to chair our discussion. Welcome back, David.
Thanks,
It's been a couple of months since we last worked together.
It was a while ago.
And joining him, our ear, nose and throat surgeon, Dr. Ian Bernardt. Ian practices in West Perth and at Fremantle Hospital. Welcome along, Ian.
Hi, thanks for asking me.
And ophthalmologist Dr. Jean-Louis deSousa, who has a special interest in ophthalmic plastic and reconstructive surgery and works at the Lions Eye Institute, Royal Perth Hospital and Meriden. Welcome along, Jean-Louis.
Thank you.
Thanks to all of you for joining us tonight. Now, before we begin, a quick reminder to you that this is an interactive program as always. So if you have any questions for David, Ian or Jean-Louis, you can have your say at any time by giving us a call on 1-800-673-277 or 089 229 5241. Take it away, David.
Thanks very much. Well, thank you for coming. Perhaps we'd like to start with a nice, easy problem. Perhaps you could tell us a bit more about vertigo and some of the ways you might like to treat it.
I really apologise for talking about vertigo, especially after the Melbourne Cup and the American elections and all this sort of thing. So I'm going to deal with the whole of vertigo, or vertigo, or dizziness or giddiness in about 3 minutes flat. And it's quite simple because the commonest cause of vertigo is a condition called benign positional vertigo, which is due to a little bit of a stiff neck in inverted commas, closed inverted commas. And it's very common. It's seen a lot more in younger people these days because a lot of people spend all day sitting in front of computers, so they immobilize themselves, they can't move, they don't move their necks, and they get this dizziness. Now, the classical history is that the patient gets dizzy when they change position. So it might occur in bed when you can't turn over in bed, getting out of bed, bending forwards, looking up to get the book on the top shelf, twisting around, driving, often in supermarkets. A lot of people complain, they're pushing a trolley and they look around to see what's on the shelf and they start to feel momentary unsteadiness, more serious when they're driving. And for the practical thing, listen to the story and they'll tell you the story. It's very easy. Have a look in the ears, and usually the ears are completely normal. If there's any doubt, and I always say this to people in the country, if there's any doubt, get a CAT scan of the head. Your patients can fly down to the nearest centre and get a CAT scan, and that covers you. If you can get an audiogram, that's useful, but CAT scan is probably more important than an audiogram.
How often would you expect that sort of CAT scan to actually throw up something with a typical story?
Yeah, I think if there's any doubt, if, for example, there's something else like a headache or tinnitus or something like that, basically you want to exclude, quite simply, you want to exclude brain tumours such as acoustic neuroma or aneurysms or vascular malformations or something like that. That's all. Otherwise, the history is what tells you. These patients, often in older patients, younger patients, when they turn around, bend forwards, you've got your story. Now, the treatment is very simple because all you have to do is neck exercises, Gary. And what you have to do is sit in a chair, and I'll give you a demonstration. And for those who are watching, watch me first, and then have a try afterwards. And I hope you're in a fit state after the Melbourne Cup to do the neck exercises without toppling backwards over your chair. This is what you have to do. Sit at the table, morning and night. It takes 5 minutes in the morning, 5 minutes in the evening, and all you have to do is turn your head in a big circle. Go around like that, over the shoulder. Down you go. You can have your eyes open or closed, doesn't matter. 10 times one way, and then 10 times the other way. But the important thing is to show your patients how to do it properly. And by doing this, you move the neck through every single movement, and you fatigue the reflex that causes the dizziness. And warn your patients that it might make them worse for the first day or two. And so that when they go home and do it, they won't say, that doctor doesn't know what he's talking about, he's making me worse. But after 2 days, they'll be cured. And what they do then is sort of keep going with the neck exercise until they forget to do it. And and that's fine, because if the dizziness comes back again, they know what to do to cure themselves.
So what precisely are you doing when you do those neck exercises?
Basically, when you've got benign position of a tiger, you've got some sort of stiffness. And I'm not, exact pathology, I'm not sure, but it could be a variety of things. And there's a reflex from the proprioceptors in the muscles of the joints up to the vestibular area of the brainstem, which sets this thing off. And by doing the exercises, you're fatiguing the reflex. You're overcoming the reflex, so it doesn't respond anymore. A lot of people, for example, I'm sure out there, can't sleep on one side or the other. They can't sleep on the right side or the left side because they get giddy when they lie on that side. All they have to do is do the exercises. 2 days they can sleep in any position they like.
I mean, I remember the Epley manoeuvre was as a thing that was taught.
See, that's based on the fact that there's, I don't want to go into details here, but it's based on a little crystal in the inner ear, in the semicircular. That's a very rare cause of it. And by swinging people around, you're supposed to shake the crystal out of the semicircular. That's nonsense.
Quite complicated to do in your
and usually,
treatment room.
Yeah, that's right. And people don't do it properly anyhow. But just the simple rotational neck exercise is what cures them.
Okay, no, that sounds great. When we talk, you mentioned there that sometimes with vertigo it might be dangerous to drive. Are there any other sort of aspects of ENT, hearing or vertigo that would affect people's ability to drive?
No, not really, because most people these days drive with the radio on, they drive with their iPods in, you know, or they drive talking on their mobile phones.
Yes.
You know what I mean? And so deafness is not really a contraindication to driving. There are a lot of old people who are hard of hearing who drive. I'm sure visually it's a different kettle of fish altogether, but from an auditory point of view, I think it's not an issue.
Okay, we might get John's views on advice about driving and perhaps some visual aspects then, just to clarify that from a point of view.
Well, certainly it's one of the most important things that you test for when you're assessing someone's fitness for driving when they reach a certain age. And the standards are quite clearly covered in the Ostroads publication, which is available on their website.
Yes.
And in terms of vision, there are 2 major criteria. One's the visual acuity, and the second is the vision field. And then beyond that, other problems that cause visual deficits, such as diplopia and scotomas that are not necessarily involving a reduction in the field to the extent that precludes someone from driving, they are also causes for restrictions. Now, I think we've actually got a slide of the Ostroad criteria here for the private standards, and these are difficult to understand because it's written in a negative form. But basically, for the private standards, for unconditional driving, the patient needs to read a 612 line with 5 letters in it completely correctly. And for the commercial standards, which is the next one, they have to see better than 6.9 with the good eye and no worse than 6.18 in the other eye. Now, having said that, there's still some leeway within the regulations to allow someone that's got poorer vision in the poor eye, depending on the circumstances and on the report of the doctor that's writing the report or the ophthalmologist. Now, for visual fields, that's a more difficult criteria, and here are the private standards. And they refer to this and they suggest that a screening test should be done, such as by confrontation. If you suspect a field defect, that formal field testing is necessary to determine whether patients have these problems. The ones that are very difficult to advise are people that have had strokes and have a permanent quadrantic defect and perhaps don't have a quadrantinopia that comes close to fixation. A lot of these patients will not meet the strict criteria for the Ostroads driving, even for a private licence. And in the country, of course, you know, the patients will tell you that they have just a short distance to travel, and it seems not unreasonable for them to drive. Now, again, there is some leeway for an individual case to be considered, and if you think that a patient doesn't meet these strict criteria, it is possible to have an in-car driving assessment. And there are some groups in Perth who will arrange for those tests to be performed for your patients if you think they will meet, they should be allowed to drive but don't meet the strict criteria.
So for a visual field, just a straight sit in front, 4 quadrants checking is ample for a private.
They would suggest that if there's any sort of defect on that testing, then more formal testing is necessary.
Okay, yes. Good. Thanks very much.
And these defects can't be fixed with corrective lenses, can they?
No, by and large, visual field defects are permanent, whatever the cause. Yeah.
There have been lots of advances in hearing aids that we've seen come onto the market, but some people do find, as they get smaller, they're more fiddly for the aged. Have they got new developments with larger knobs or easier to fit? for the elderly?
Well, there have been some developments since, in the last year or so. And, for example, beforehand, well, in the old days, people used to use the old British National Health Service, which is the best way. You have your amplifier there, a wire going up to your ear. Everyone knows that you can't hear, and they all shout straight in.
It's like being at a drive-in movie, wasn't it?
That's right, like Faulty Towers, you might remember. But and then they had the post-oral hearing aids, which are the sort of things you see in a lot of older people. Then they developed smaller and smaller intra-oral hearing aids. But what they've got now, in fact, are beautiful little post-oral. Well, no one wants to hear a hearing aid, but little post-oral hearing aids where you've got a small insert with a transparent little tube going to the back with a tiny little amplifier behind. Because the further away the amplifier is from the actual insert, the more the more you can amplify the sound without getting feedback. And I see now they've got little trendy little things. So, for example, I saw an advert in a medical journal last night, believe it or not, where a woman was wearing a leopard skin coat and she had a leopard skin hearing aid to match her
accessory.
That looked very nice.
So there's lots of advice, but for the very fiddly ones, it's better to perhaps go with
for older people, I think if you want maximum amplification that's simple to use, the ordinary old-fashioned one, post-oral aid, if you can cover it with your hair, that's fine. That's an easy one to use.
Are hearing aids suitable for every kind of hearing loss, or are there kinds of hearing loss for which you can't fix with a hearing aid?
Sure. Look, there are two things about hearing aids. As a rough guide, there's no sort of fixed laws or about hearing aid. If you're in a one-to-one situation with someone else and you have to shout at that person, then that person needs a hearing aid. In a one-to-one situation without any background noise, as we're talking now, if you can hear well, you don't need a hearing aid. A lot of people who have got a bit of a hearing loss due to age have difficulty in restaurants when there's a background noise. A very good practical tip for these people and for all of us, especially politicians, is to sit with your back to the wall. And when you sit with your back to the wall, you get maximum amplification from the wall. So if people at a bridge meeting or in the country, at the municipal meeting or town hall or something like that, sit with your back to the wall and you'll find you'll hear
it's like
much
an acoustic
better.
reflector.
That's right, exactly. Now, the last little point I want to make is that the principle of a hearing aid is to wear it in your better hearing ear. Okay? So if your better hearing ear is normal and you've got a lousy, less hearing ear, you don't need a hearing aid. So you always wear your hearing aid in the better hearing ear. With technology now, I think there's come a time very soon when you go to Kmart or Coles and wheel your trolley out, there'll be disposable hearing aids next to the chewing gum and the sweeties. And, if you get a pair of hearing aids for $15, chuck it in the basket and walk out and use it for 2 months or 3 months and then buy another. That's going to happen soon, yeah.
So they're going to be getting cheaper all the time?
They should be, yeah.
Cost is quite an issue for some. What about nosebleeds? Can be quite frightening and quite messy when someone with a severe nosebleed turns up in your surgery?
It does, I'm sure it does, yeah. The two types of nosebleed or epistaxis. The first type, more common type, is the anterior epistaxis, where you get bleeding right from the front part of the nasal septum, called Little's area. And that's easily treated by getting the mum or the patient to just squeeze their nose down there, not up on the bridge of the nose, down here for 5 minutes, and that'll stop 100% of all anterior nosebleeds. It's as simple as that.
So the cold pack on the back of the neck?
Cold pack, key down your back, it doesn't work.
Doesn't make any difference.
Just squeeze your nose. But most people tend to squeeze in the wrong spot, right down below. The child can squeeze his nose.
Yes.
You can teach kids, if they bleed in the playground, just squeeze their nose. If you want to cauterize, I've got some stuff here, but basically if you want to cauterize the nose, it's easy to do. And in the country, all you need to do is a little bit of phenylcane spray, a bit of cotton wool, put the spray on the cotton wool, lift up the nose. It's very easy. And with a pair of forceps, anything you've got, pop it into the vestibule, give it a little squeeze to push the cotton wool onto the septum, put the patient outside for a good 15, 20 minutes so that the local anesthetic works. And then get them in. And you can do this probably in a child from about 7 or 8 up, and certainly in adults.
So you need to have a little bit of cooperation from the child.
Yeah. But if there's no,
so 7 or 8.
Usually can 7, 8. Yeah. And give it a squeeze. Make sure that they're out there. And usually the topical anesthetic works, and their teeth get a little numb, and then you know that And then what you use is a silver nitrate stick. Sorry, I should have opened this. Never mind.
Here's one I prepared earlier.
Yes.
Sorry.
And you just dab that onto the...
Yeah, I don't want to waste time. And what you do is you just lift up the nose, get someone to shine a torch, it's like a matchstick. Stick it onto the nasal septum and just wait. Okay? Keep your little cotton wool ball, because sometimes it might start bleeding, in which case just pop it in again, give it a squeeze, get them outside, bring them back in there. And that's
so you might have to apply that pressure with your silver nitrate stick for a few seconds, or
just for about 2 minutes. I usually
about 2 minutes.
Yeah, and if they school kids, I always say to them, "Well, what's the name of the Prime Minister?" You know.
And then by the time they work that one out,
what's your teacher's name or something like that, and that's it. Now the second type of epistaxis is a posterior epistaxis. And you know that it's a posterior epistaxis because you squeeze the nose, and it's bleeding from somewhere behind where you're squeezing, so the blood comes down the throat and they start spitting blood out everywhere. And so that's a posterior epistaxis. You never know where it's coming from, and the best way to treat that is, in fact, especially in rural and remote situations, in a country town, is to give the patient some pethidine or morphine, admit them into your hospital, and that'll stop 90% of posterior nasal bleed. So you don't have to pack the nose. Okay, get them to blow their nose hard, and that'll stop it. Well, how? Because it lowers the blood pressure, it sedates the patient, and then the little blood vessel, wherever it is at the back of the nose, retracts, clots, and organises and fibroses, and that stops it. Okay?
Perhaps you could just show us the...
now, if that doesn't work,
pad.
then the best way, and this is the best thing since sliced bread, I might add, this is called a Mericel pack or Pope pack. And if the bleeding still occurs after all that, they've had their pethidine, so they're well sedated, then what you do is you put a lot of KY jelly on the pack, pass it into the nose, go posteriorly, not because your nostril goes that way, don't stick it up into the brain, go posteriorly.
Always a good tip.
And but lots of KY jelly, and then it'll swell up. So it fits in nicely, it's nice and firm, and then I've got my water here. So you'll see what happens as we talk, and it starts to get a bit floppy. Yeah. So you don't want to wet it first.
Oh, it's swelling up now.
Because otherwise you'll need a little bit of Viagra or something to get it to stiffen up a bit, right? Get it, okay.
But
and it expands. Now, if there's still a bit of bleeding, you can slide one in on the other side, and for a bit of counterpressure, you can even put a second one in on the same side, but just lots of KY jelly, and that'll stop most of your bleeds.
Right.
Leave the pack in for 48 hours, give the patient some antibiotics. You can't send them home with a pack in their nose, so they've got to stay in hospital. And then you're doing the same thing. You're stopping the bleeding, retracts, clots, organises.
Well, we might leave Ian's bloody nose to heal there for a few moments. Now, there's an ever stronger link between unmanaged hearing problems early in life and the ongoing ability to understand and use language over an entire lifetime. Dr. Harvey Coates is responsible for implementing the newborn hearing screening program in WA. He spoke to us about the importance of identifying hearing problems early in a child's life and putting in place corrective measures to give the opportunity for normal language development. We also spoke to Jan Mclean, the coordinator of the WA newborn screening program, who talked us through the screening of a newborn baby.
It's critical that children have their hearing picked up, hearing loss picked up early. Now, why? Well, because it's to do with neural plasticity. The brain is ready to accept a stimulation of the auditory pathways up until the age of 6 months. After the age of 6 months, other parts of the brain will take over the function, and the auditory pathways will not develop as well as we'd like.
And although a child will be able to acquire language skills, they will not be on a par with their peers. So to achieve that result of a child having equal opportunity to its peers, then it has to be identified very early and intervention commenced.
I think this applies not only to children that have sensory neural hearing loss, but also to Indigenous children, and obviously we've noticed that spiral of despair much more so in the Indigenous children with a 40 or 50 decibel conductive hearing loss. But this obviously applies as well to the children with sensory neural hearing loss. So they'll have problems acquiring language, they'll have social problems, and they'll feel socially isolated. They will have issues learning at school. They'll have problems with getting jobs later on in their life. And in addition, there are problems with the law and there's a very high number of people with hearing loss that are, particularly in the indigenous people, in jails, unfortunately.
Thousands of infant responses to this sound. And
there's work from an American called Christy Yoshinaga Atano, which is a seminal work in this field, and she says that you must detect the child's hearing loss, preferably by age 3 months, and have them fitted with either a hearing aid, later a cochlear implant by 6 or 7 months, as they're doing them now, or start a sign language program for those parents who wish to do that. And as long as the child has some form of auditory stimulation or communication starting at that age, then the child will develop language, not necessarily speech, the same age as a hearing child. This has been shown in a new study in Australia, in New South Wales and Victoria, where they have a newborn hearing screening program in New South Wales, and Victoria only has one in the main cities' centre hospitals and birthing hospitals, much like in Perth. And they've been following these children, and there's a dramatic improvement in the speech and language development of those children in New South Wales compared with those children who are picked up later, as long as 18 months to 2 years after birth in Victoria.
So it's nothing that worries him. We do have to do this when they're asleep, because these little sensor patches pick up any muscle movement.
If there's any reason at all that you suspect this baby may have a hearing loss, then if there's a regional audiologist, then that regional audiologist should see the child. Most of them have some means of objective testing of this child, whether it's an OAE machine or an AABR. If not, then I think the child will need to be assessed in a centre such as Princess Margaret Hospital for Children or the Telethon Speech and Hearing to ensure the child doesn't have a hearing loss. It is critical. It is critical, and if a mother feels her child has a hearing loss, then one should always listen to that. In addition, the other important fact is that even though the ear may look morphologically normal, the child can still have a hearing loss, a permanent hearing loss, and we can do a hearing assessment on any child from day one. We have a situation where children are born in Western Australia, and even in Perth, they cannot have their first hearing test until they're 5 years of age. So if a child's deaf or even has an acquired hearing loss rather than a permanent hearing loss, they may not be picked up. And this applies to hospitals like Swan Districts, Bentley, and so forth. Every other state is now introducing newborn hearing screening, as is New Zealand, all the states in the US, Great Britain, and many European countries. It's gold standard, state of the art.
We set up the baby first, prepare the baby, attach ear couplers, and we attach little electrode stickers to the front of the head and the nape area, and one on the shoulder. And the baby will hear a series of clicking sounds, and the machine will then pick up the baby's brainstem response. In this screener, there is a template that has been compiled of thousands of infant responses to these clicking sounds. So the machine gathers information from the baby, matches it to the template, and when it's satisfied that it has gathered enough matches, then it'll be content to pass the baby.
We are going to have newborn hearing screening. The last minister saw the evidence base and felt that it should go ahead, and the new health minister has decided that we should continue with the rollout of the universal newborn hearing screening in Western Australia. Now, how this will happen is that initially in a 3-year program, the first year, all the places that are having newborn hearing screening done currently will change the technology from the current 2-stage OAE AABR technology to a 2-stage AABR technology. The second stage will be that all the birthing hospitals in the metropolitan area will then have the same technology introduced, and the third year is there will be rural and remote hospitals supplied with the equipment and universal newborn hearing screening for all children. And this is going to be have to be a moving feast. I know in New South Wales they've actually got state area managers who follow up on every child, and they'll even drive 3 hours to a remote community to test a child, and I think we may have to do that in Western Australia as well. But we hope that we can capture the children while they're in the birthing hospitals, or the parents may come back to a clinic that's held periodically, perhaps every week or every 2 weeks, where the children can be retested, preferably before the age of 3 months.
So it's hearing little clicking sounds in both ears at the moment. The machine will continue sweeping for 15,000 sweeps, and if a pass is not gained at that stage, then it will give a refer result. And a refer result does not necessarily mean the baby has a hearing loss at this very early stage. It can still very much be just fluid in the ear, debris in the ear. The baby may be a noisy breather, so we're purely doing a hearing screen. If a baby doesn't pass the screen, then we will book an outpatient appointment. The baby will come back in 2 weeks' time, and if the baby refers on that second screen, then we'll refer to audiology at Princess Margaret Hospital, and the baby will have diagnostic testing at that stage. So babies should usually be about 2 weeks of age if a hearing loss is diagnosed. And we also just check when we're doing the screen if there's any family history of hearing loss. If there's anyone in the family who has any hearing problems. No. Okay.
This is a century of communication, and if you can't communicate with other people, and your only other way of perhaps getting a point across is aggression, or you can't get a job, and you therefore have to acquire money by stealing it or whatever, then this is happening. And there is evidence from Darwin Jail, for example, of the very high number, disproportionately high number of Indigenous people who are deaf who are in that jail.
Babies can now be fitted with hearing aids as early as 6 weeks of age, and that's going to allow them to hear language, from the very first few weeks, and which makes an incredible difference in achieving the language skills and cognitive skills that will allow them to be in a par with their peers. Okay, so he's passed his left ear, and he's passed his right ear. Good boy.
And our thanks to Dr. Coates and Jan Mclean for taking the time to talk to us. Now, before we return to our studio discussion, a reminder to call in at any time if you have any questions or comments for discussion. The number is 1800 673 277 or 089 229 5241. David, we're taking a look at eyes with this next question, are we?
Yeah, I think we'll try and focus a little bit more on eyes. John, perhaps you could give us some updates with regards to macular degeneration and some of the new treatments that are becoming available for this.
Yeah, I mean, this is a revolution in ophthalmology over the last couple of years. For macular degeneration, a few years ago, we had nothing to offer patients other than magnifiers, and unfortunately, all of the treatments to that point were very poor at reversing the damage that was done. This is obviously an age-related change, and you may be aware of the two types of macular degeneration: an atrophic change, where there's a breakdown in the cellular debris from the epithelium, the retinal pigment epithelium, that results in the loss of function, and then what's called a wet form, where new vessels form in the retina and then leak fluid and cause very rapid reduction in vision. Now, for the wet form, the neovascular form, in the last few years, medications that target the molecule vascular endothelial growth factor, which is present in the eye, but also increasingly recognised as a factor in tumour proliferation and tumour metastasis. But these agents have been targeted with specific therapies for the eye, and they are actually able to improve vision in the cases of some patients that have lost some with early stages of wet macular degeneration. And these agents are given by intraocular injection. and they need to be repeated at varying intervals. And at the moment, it seems to be about 6 weekly intervals, but perhaps with the newer agents that are coming out, that duration of treatment will be extended. But it is quite an intensive course of therapy for patients.
So it's a 6-week injection. For how long would the injections be? Forever?
Well, indefinitely, yes, that's right. Obviously, the companies, the people that make these medications are working on longer acting agents and perhaps implants into the eye that might deliver the agents for a longer period of time.
And cost is covered by the PBS, or?
Well, that's right. For one of the agents that was put onto the PBS at the end of last year, the patients need to meet quite strict criteria to qualify for that, but that does greatly reduce the cost of treatment for the patients.
Can these injections be administered by a GP, or does it require the services of a specialist?
No, these are by a retinal specialist by and large. There are general ophthalmologists can deliver these treatments, but the diagnosis requires quite sophisticated testing of the back of the eye to determine the nature of the problem, both for qualification purposes for the medication and to determine how long the treatment will need to be given, for example. And they do those tests again later on to determine whether the treatments are effective.
As a GP working in the country, can you pick your macular degeneration patient that would benefit from the treatment?
Well,
or are they essentially all going to need to be referred to be assessed?
Generally, the patients who present with macular degeneration in the first eye often present very late, because if you lose central vision in an eye and you've got 2 good eyes, you tend not to notice it. If it's the second eye that starts to become involved and it's a sudden change in the central vision, then those patients should definitely be assessed, because this form of therapy offers the chance of retaining vision, which might even be at a useful standard for driving, for example, if it can be delivered in a sufficient amount of time. And for these sort of changes, that amount of time is a matter of weeks before there's some established changes in the retina.
So you need to move quite quickly once you're concerned.
That's right, and ophthalmologists would be quite happy to see these patients at very short notice with this in mind. And of course, that's more the case with a second eye becoming involved.
Sure.
With a first eye involvement, they tend to present a bit later. So unfortunately, we don't tend to pick them up that often. But again, if there's a sudden deterioration in vision in someone who's been noted to have mild changes of macular degeneration by their optician or their ophthalmologist, then we'd certainly want to see them quickly.
What about cataracts? A lot of people have cataracts. A lot of treatments have been available over the years. Are there any new implants or techniques that are being used?
Yeah, well, cataract surgery these days is a very quick and safe operation, and there are a couple of changes. The surgery itself is in evolution, and it's small incision surgery that's getting smaller and quicker as we speak, with new instruments being evolved to do that. So now we're doing cataract surgery through incisions that are around 2 millimetres in size, and getting lenses that go into those. The other major advance has been the injection of intraocular antibiotics at the end of cataract surgery, which has greatly reduced the complication of endophthalmitis, which was a very devastating, sight-threatening complication. And since the advent of intraocular, and we use cefazolin or cephalosporin at the end of the surgery, the rate of endophthalmitis has greatly reduced. So it's become a very safe procedure. In fact, in some other countries, they do simultaneous bilateral cataract surgery because the visual recovery is quicker, and with the reduction in that particular complication, it makes that procedure a bit safer.
Yep.
In terms of lens technology, there have been some developments, and lenses have got much better over time in terms of their monofocal lenses being able to give patients better visual acuity. And that's important for us because increasingly we're doing cataract surgery on patients who've got better vision. They're no longer almost blind before they're coming for cataract surgery. So the monofocal lenses are giving very good visual outcomes. And now we have lenses that can focus at different distances as well. So these are pseudo-accommodative intraocular lenses which can focus for distance and for near. They've been around for a few years now. They are in evolution, and they are for select groups of patients only, and patients without very high demands for visual acuity, because the vision at each distance is slightly compromised by that method, but they can be free of spectacles.
And how long do they last, Jean-Louis?
Well, these lenses, they stay in the eye forever. They outlast the patient. Yes.
They outlast the patient.
Yes. The history of intraocular lenses is the idea first came about after the Second World War, when World War II pilots were found with perspex from their cockpit shields inside the eye, and it was seen that they were quite inert. So we've used similar types of materials, and the new ones now are silicon or acrylic-based intraocular lenses, and they certainly last longer than people do.
What about the sort of post-op follow-up? I mean, if they were done as a day case in Perth and then swiftly went home.
Yes.
What would the GP be expected to be looking at and following up?
We also do cataract surgery on a day case setting in rural and remote areas and with the fly-in, fly-out visits. And our standard in Perth would be to see a patient at the first day for a post-operative check, mainly of the intraocular pressure, and then we would see them at 1 week to ensure that there's no problems. Most of the major complications will occur within that first week, and then at a month to ensure that the eye has settled down without any inflammation and to check their refraction to see if they need distance glasses. Now, if it's done in a remote setting, we usually endeavour to try and see the patient on the first day, or at least a few hours after the surgery, to ensure that the lens is sitting well and there's no leak in the eye. And then after that, they can just be screened by an optometrist, or even the GP can do a screening test for them to check their pinhole acuity and their unaided acuity at a month to ensure that that's recovered. Endophthalmitis is the devastating problem that we are worried about. It typically presents within the first 5 days, and needs very urgent treatment with intraocular injections of antibiotics if there's going to be any potential for restoring sight in the eye. But as I say, with the
so
intraocular...
would be pain or
yes,
worsening vision?
Usually pain, redness and loss of vision, but you don't have to have either the pain or the redness, or there may be some redness from the surgery as well. So loss of vision is the cardinal sign that you're looking for. Typically after topical or local anaesthetic cataract surgery, vision is quite good from the first day, and the patients will notice that. And if they see a reduction in vision over the course of the first week, particularly a drastic reduction, we need to see them urgently.
Is there anything new in the literature about prevention of these kind of conditions, which would remove the necessity for all sorts of foreign bodies being inserted into your eye?
Cataracts, unfortunately, no.
No.
And I suspect that if a pill came that was going to treat cataracts, we wouldn't be that happy about them.
What about diabetes management?
Yes.
And if improving diabetes, has that been shown to reduce cataracts? Yes.
Oh, not cataracts. No, cataracts will occur, but a little bit earlier in diabetics.
But there's improving diabetic will help with retinopathy, but not
absolutely yes,
not
but not with cataracts. No. Look, cataracts. There is probably a relationship with ultraviolet light exposure, but cataracts occur at all latitudes, and it's more an ageing change in the crystalline lens of the eye. So there's no preventive treatment for that. For macular degeneration, there has been a large population study which showed a benefit of antioxidant vitamin supplements, and they are now marketed as well in chemist. You can buy the vitamin supplements for macular degeneration. They were only ever shown to be of low-grade benefit to patients with established macular degeneration. So the jury's still out as to whether taking these sort of supplements and other enzymes or nutrients that are present in the retina.
Hence the theory that carrots were good for your eyesight?
Yes, the pigments in carrots are some of the things that they're looking into in terms of preventive treatment, and it certainly hasn't been shown to be any harm, but because the effect of these things is going to be so small, you'd need to study a vast number of patients to show any benefit.
What about sunshine? Is that in any way related to macular degeneration?
Again, there's no clear link, and they do have large population studies which can link with latitude. But certainly we think that ultraviolet light might be important, and some of the intraocular lens manufacturers put blue blocking pigments in the lenses so that the lens cuts out the shorter wavelength light. Okay. But there's no strong evidence, no.
Cataracts aren't the only foreign bodies that we can get in our eyes, so have you got any tips for GPs in country areas for what danger signs for other foreign bodies that might get into our eyes?
Well, I think in terms of industrial type of injuries, the main issue is the history. And if it's a patient that has a history of hammering metal on metal, where there's a high-speed small fragment that could be possibly penetrating into the eye, you need to be very suspicious about an intraocular foreign body, regardless of the symptoms. If it's a grinding injury or a speck of dust that's flown up, those tend to be present on the ocular surface and have not penetrated the eye, and that's not a concern in terms of the vision, but obviously a management concern. So for a corneal foreign body, the key elements to treating it are adequate magnification and illumination. Now, if you've got a slit lamp, that provides both of them, but it can be quite difficult to use a slit lamp and to hold a needle to remove foreign bodies if you're not used to it. So head-mounted magnifying loops and a bright examination light with a patient lying comfortably in bed with an anaesthetised eye is a good start.
Yes.
Get them to open the other eye. If they're closing the fellow eye or not focusing on something with the fellow eye, then the eye you're working on will drift wherever the other one is. So make sure their other eye is open and give them a fixation target. So tell them to look at something on the ceiling and then with your steady hand, and I'd suggest you use a needle, because most of these are very small foreign bodies. If you don't have a needle, a blunt surgical type instrument like a Chalasian curette, the wax hooks that I think we've got one of these here, these sort of things won't go into an eye, but neither will a large gauge needle very easily anyway. Yep. So I would use a 21 gauge or 23 gauge needle. Yep. I put a little flick on the end of the needle so that you've blunted the barb, the very point of it. Yep. And then you just need to use a very gentle flicking action, usually to remove.
And if there was a little bit of a rust ring, or if it's been there for a couple of days.
If there's a rust ring, I wouldn't be too concerned about removing it in the first instance. They separate a lot easier after a couple of days. So get the main foreign body out, give them some antibiotic ointment or drops. Yep. Don't pad the eye, and get them back in a day or so, and the rust ring will shell out a lot easier, even with a needle again, or one of the dental burrs.
Which are the where are we most likely to get corneal scarring, and is there a particular patient that you'd be worrying about to end up with corneal
any
problems?
time you get a corneal foreign body, it will leave a scar. So the scars that we don't really want to get are the ones that are in the visual axis. So a foreign body that's close to the visual axis, if you're concerned that it's going to leave a scar, it might be worth them seeing an ophthalmologist. Mm-hmm. Once there's a scar in the corneal stroma, the only treatment really is a keratoplasty, a corneal graft of some type, to remove the scar and restore the vision. So there's an opportunity at that stage to remove the foreign body completely and to use some steroids possibly afterwards to modify the healing response to minimise scarring.
Great. And what about foreign bodies in ears or noses, Ian? Have you got any tips?
Well, I think foreign bodies in the ear, for the most part, if you could try and syringe it, and if that doesn't work, you need to send the patient in to see an ear specialist with a microscope to take it out, especially in kids. Foreign body in the nose, I don't know if we've got enough time to describe it. Foreign bodies in noses are usually only done by 2-year-olds. At the age of 2, they stick things in their nose. Above 2 is very unusual.
That's what noses are for.
That's exactly right. So if a 2-year-old comes along with a foreign body in his nose, usually you don't know about it until there's a stench that comes from somewhere inside the house. And you think, well, there's a dead rat in the roof or something, and eventually you locate it to your little 2-year-old child, and you start to smell, you can't get near the child. And you can remove that, especially in a rural and remote situation. The big tip is to get the mum and the dad out of the room, point number 1. The second point is you need 2 assistants. One assistant to wrap the 2-year-old in a blanket or a towel, legs between the assistant's legs, the child's immobilised. The second assistant stands behind and holds the child's head, and that immobilises the child. And then you can use a wax hook like this one here. You don't really need an anaesthetic, and once again, this is blunt, so it won't cause any damage, and you pass it along the floor of the nose, not up that way. Mm-hmm. Once again, you don't want to go through into the brain. So you go along backwards, and you can flick it out. And it usually comes out with blood and a bit of mucopus, a bit of snot and everything. The child screams his head off, so that's why you want the parents well away, and then it's out. So that's pretty straightforward. If there's still a bit of a discharge after that, a week later, there may be a second foreign body there. People don't realise. Sometimes the kids put 2 things up. They put second one up their nose to try and get the first thing out, you see. So you might need to do it twice. But after that, no child of 2 will put anything up his nose again.
Jean-Louis, we're almost out of time, but I wanted to ask you about laser surgery to correct vision. Some people are claiming it as a miracle cure, but obviously it doesn't suit everybody. What's the criteria? What do you say to patients who say, I could love to get rid of my specs and have laser surgery?
Yeah, well, it is not for everyone. You're quite right. The thing about optics in the eye is that it's physics that governs what we see, and we can calculate if someone can have a treatment done to the surface of their eye, and these laser treatments are done on the cornea in order to focus light in the retina accurately. So it all depends on the refraction, so how short or long-sighted the patient is, and how thick their cornea is. Okay, and the third function is whether they've got a cataract or not. Because if they've got a cataract, when we take that out, we actually get rid of any refractive error at the same time. So patients who are approaching the age where cataract surgery is necessary won't be recommended LASIK surgery. So refractive surgery then on the cornea is limited to patients with refractive errors around about plus or minus 5, not so much plus 5, but around to minus 5 diopters, depending on the individual cornea. And if it's any higher than that, there are other refractive procedures, but they involve operating on the inside of the eye.
And the effect is permanent?
It is, but as I say, if you develop a cataract later on, that will independently drop the vision, and then the cataract will need to be removed and replaced with an intraocular lens. But the effect on the cornea is permanent, yes.
Okay, thanks for that. Well, our final story tonight looks at sight screening for children. We went to Princess Margaret Hospital, where ophthalmologist Dr. Anita Tandon and orthoptist Sarah Ashurst gave us some tips and advice for an easy and fairly comprehensive sight screening test for children that you can perform quite easily in your own rooms with limited equipment. We started by asking Dr. Tandon for her tips.
The first thing to try and do is to engage the child. You frequently need to seize the moment. Often there isn't any time to actually ascertain the history, because as soon as you get the child, that's probably your best opportunity. I have no qualms about making a fool of myself. Singing, squeaky toys, noises, all of these things work well. Blowing raspberries, anything to get the child to engage with you, and then stopping making your noises so that the child then follows you, having attracted their attention purely on a visual basis. I try not to get the parents to hold the child's arms. They're often inclined to try and help you by pinning them down or restraining them. That generally is counterproductive, because the first thing the child will do is shut their eyes. So as little pinning down of the child as possible, being prepared to just make a fool of yourself. Sing, make noises, do whatever you can to get the child's attention.
I'm just going to shine the light and just look to see where the reflection is on the pupil.
Sure.
Basically, the first thing that I would do is, or the first thing you're looking for is, you would use your pen torch and basically look at the corneal reflections to make sure that they're symmetrical. Probably one of the most common things that are referred, or people that come along, are actual pseudo-strabismus. So that's where the child looks like they have a squint, whereas in fact they haven't. The eyes are nice and straight. And often if they have large epicanthic folds, that can make it look like there's a strabismus there when there's not. So yes, you hold your pen torch up and basically look for the corneal reflections to make sure they're nice and straight. So you're still looking at the light, watching the light for me. You can then go on to try and do a cover-uncover test, where you'd use your hand or an occluder if you had one, and basically cover up each eye, or either eye, and you just say, for instance, if you cover the left eye, you're looking then for any movement in the right eye, either in or out, and vice versa when you swap over and do the other eye, and that just tells you if there's a manifest squint there. Okay, so if you can look right at the light there and just keep your head nice and still. Then I'd basically go on to do ocular movements, which is exactly the same thing as doing your corneal reflections, but you're just doing it in every position of gaze. So you get them to look all the way over to one side, all the way over to the other, up, and look in the positions up there, and then looking down as well, and look in the various positions there. Go down to this side. And this side.
The important thing to do with any child is try and ascertain some level of vision. Now, testing with a Snellen chart may not be possible, obviously, for a young child, but whether the child is fixing or following as an infant is an important thing to ascertain. So it would be fantastic in every child, particularly a newborn, if they're referred after the 6-week check, for example, to test the vision in either eye by occluding one eye and seeing if they are able to follow a toy.
It's not very often that they'll look for very long at a pen torch, because it's not very interesting, so we just use a variety of squeaky toys and just basically whatever you've got to hand. Sometimes parents will, if they like car keys, they'll sort of use a set of car keys, just if that's what fascinates them, just to sort of get them to follow those.
Always important to make sure that you're not making squeaking noises with the toy or talking to the child as you move, because that will stimulate the child in an auditory fashion rather than purely visual. So what I often employ for a newborn or a 6-week-old baby that's come to see me because of concerns at the 6-week check is to just follow that child and move my face and see if they will track with both eyes. It's also really important to check the red reflex in both eyes separately. This can show you if there's a problem with the red reflex or leukocoria. And And it's, however, sometimes deceptive because children with very darkly pigmented skin can also have darkly pigmented fundi, and that can sometimes cause some confusion with regards to finding the red reflex.
Can you find this one on your card?
In an older child, fix and follow is still important, possibly then of a slightly smaller toy or a smaller stimulant, and then also trying to achieve measure the visual acuity, such as with K picture testing. The child health nurses use the Lear symbols, or using a Sheridan-Gardner test, a series of cards which are graded in size for use at a 6 metre distance. The child then has to match the letters. The child doesn't have to actually know the names of the letters, it's enough simply to point to each letter as they are matched.
Yep. Excellent, well done.
It's difficult to fully reassure a patient or a parent once you've seen them when you have just checked the cover test and the red reflex alone. When a child is referred to us, we're able to put cycloplegic agents in, which dilate the pupil, allow us to perform a full fundus examination and look for any anatomical abnormalities, and probably even more importantly, allow us to check the refraction and ascertain if there is any refractive error. Cover testing will obviously exclude any major deviation, particularly ruling out what is often the main source of a referral, which is a pseudostrabismus. One common assumption that is made is that there is some turn that is normal in a newborn baby. No turn is normal at any age. So if an exotropia or an esotropia is found even in a newborn, it's not generally reasonable to assume that the child is going to grow out of it. It generally isn't safe to say that we can wait until they're a year or 18 months old before referring, because frequently an early onset turn can be a sign of major pathology. So one thing I would say quite strongly is that no turn at any age is normal, and even at a very early age of 3 months of age, we can perform a fundus examination and a cycloplegic refraction to see whether this is a significant turn or not.
I'm going to get you to hold your...
A child whose eyes turn when they're tired can be a sign of true pathology, or it can be a sign of pseudostrabismus. So unfortunately that's a difficult one to separate out. Again, performing a cover test, trying to check and see if that vision is present in both eyes, and also looking for the red reflex can be of some reassurance, but it's difficult to, if the examination is normal, to say, well, this is normal, there's nothing to worry about, because there may be a turn which is only present some of the time, which is still in evolution. In the presence of a normal cover test, normal eye movements, seemingly able to fix and follow with both eyes, and a normal red reflex, it probably is reasonable to watch this. That reported finding, the eyes turning when they're tired, can often decrease as the child gets older, particularly if there are broad epicanthic folds and every reason to believe that this is a pseudostrabismus. Any question about the child's ability to follow or to fix, any leukocoria needs to be referred straight away. If you cover up one eye and the child clearly cannot see anything, that needs to be referred straight away by means of a telephone call to either your local paediatric ophthalmologist or to Princess Margaret if necessary.
So that we don't have to stick it on your face, if that's okay. If the child won't cooperate, basically the best thing is to bring them back again at a later date and try again. If they're tired, you know, parents often say, oh, well, they've missed their, you know, I could only get this appointment time. This is usually when they have their nap. Try and get them in, you know, first thing in the morning when they're better, when they're fed, with different toys. But yeah, basically bring them back on another day and retest them. It's not quite old enough to read the alphabet yet. So basically what I'm going to do with this test is I'm just going to hold up the card. I'm just looking to see where her eyes are moving, so she doesn't have to point to the picture or anything like that, or, you know, tell me what it is. I'm just looking where her eyes are.
I do appreciate that it is very difficult for general practitioners because a vast range of eye problems will be brought in to you. I would like to be able to give you a pearl whereby it will completely ascertain that this is safe and this is not safe, but unfortunately it isn't often as straightforward for the GP or for me. A child that is referred by a child health nurse tends to have about a 50% strike rate in my experience. 50% of them will have nothing wrong, and 50% of them will have something significant requiring glasses or other intervention. And frequently from the child health nurse assessment, it's difficult to distinguish between the two. So therefore it's entirely reasonable to refer somebody if it's not clear and if you are concerned, because oftentimes we don't know either on the basis of the child health nurse assessment.
That's great, well done. Yay.
And our thanks to Dr. Anita Tandon and Sarah Ashurst from PMH for taking the time to talk us through the screening, and also to young Darcy and Imogen, who, sometimes a little reluctantly, obliged us by being screened. Now, Jean-Louis, how do you tell the difference between a non-response in children and a child who's just tired or shy or just plain over it?
Well, it can be very hard to tell, and sometimes it's you just have to bring them back at another time. And as Sarah was saying on the video, particularly a young child, when they're fed and have just had their sleep, it might be a better time to get their response. In those pre-verbal children, we're just looking for typical responses that a child will make if they can see a stimulus. So we know how a child will behave. It's very much like an auditory distraction stimulus, a visual stimulus that's different from their surroundings. They will look at it. And if there's a doubt, we'll just see them at a better time.
Now, we did have a call in the break about what happens when you're trying to get your rustering out from your foreign body and you can't get it all out. What should we do then, John?
Well, the rustering is actually a cause for an ongoing foreign body sensation. So part of the rustering that you're seeing is a bit of a slough and some pigment left over from the foreign body, which is not necessarily metal, I must say. Sometimes you get these rust rings to a vegetable matter type foreign body. So if you've left it a couple of days, they typically do shell out a little bit better from the remaining stroma. But occasionally you will see some pigment left behind in the cornea, and as long as there's no significant inflammation and the epithelium is healed over the top of it, it's not necessary to completely remove all of that pigment. That may just be there with them forever.
Ian, any take-home messages from you? Any pearls of wisdom to leave our GPs with?
Yeah, look, I always admire the rural and remote GPs because they're out there on their own dealing with all sorts of problems. And I would say the best thing I could advise is find yourself an ear, nose and throat surgeon who you can phone regularly. If you have any questions or problems, don't be shy, phone the guy. I'm always available, but lots of my colleagues, we enjoy getting phoned from someone in a rural or remote area to discuss a problem. And often, most times, the problem can be solved locally and the patient won't have to come down to Perth.
David, have you ever had to extract anything weird from an orifice, like a nostril or an ear cavity?
No, I can remember seeing a photograph once of what was described as a foreign body in someone's eye, or a piece of wood in someone's eye, and it actually was a huge trunk of a tree that had managed to go in.
I've seen that photograph.
Yeah, and the underlying message was, whatever you do, if you've got a penetrating foreign body, don't take it out.
Well, that's all we've time for tonight. Now, don't forget, if you'd like to review this programme or any previous programme, a delayed transmission will be available via internet web streaming early next week, though through the Rural Health West website at www.ruralhealthwest.com.au. And you can watch the programme online or download them as video or audio podcasts and listen to them at your leisure. Now, this is our final programme for 2008. I hope you've enjoyed our programmes this year and found some benefit from them. We will be back again next year on the 3rd of February 2009, and that's a threat, with a programme that is most vital of topics, and that is cardiology. We've already started work on this programme, so if you have any questions you'd like answered, then please get those evaluation forms into us as soon as possible. So on behalf of everyone at Rural Health West, I'd like to wish you a happy and safe festive season, along with our sincerest hopes that you get a break from your practice to spend some time with friends and family over that festive season. Thanks again to our studio panel tonight, David Jameson, Ian Bernard and Jean-Louis deSousa. And thanks to you for taking the time to join us. See you next year.